Well, welcome everyone to our webinar sponsored by the Transplantation Society. I'm pleased to be with you today. My name is Joseph Leventhal. I'm a transplant surgeon and scientist who works at Northwestern Medicine in Chicago, Illinois. I'm also joined today by Gisela Delgado, a patient and transplant recipient. And today we'll be talking with you today about immune tolerance and harnessing the power of immune tolerance in kidney transplantation, focusing specifically on FCR001 and investigational allogeneic cell therapy. I'll be providing sort of an overview of the landscape currently in kidney transplants and the importance of tolerance induction and our experience of FCR001. And then I'll be turning the floor over to Gisela, who will give you the patient's perspective regarding the journey that one makes with transplant. And then we'll open up to questions. And please feel free to put your questions in the Q&A for us to respond to at the end of the presentation, but put them in as we go through it as those questions pop into your minds. Again, this is who I am. In addition to what I've mentioned previously, I also serve as the director of the kidney transplant program here at Northwestern. And I have received grant support from Talaris Therapeutics, which is developing the FCR001, a single-dose investigational cell therapy being developed for use in solid organ transplantation, specifically living donor kidney transplantation. So what are today's objectives? Well, to recognize the treatment burden that's associated with chronic post-transplant immunosuppression, to introduce to you FCR001, to review the outcomes of a phase 2 trial that we've been very closely associated with here at Northwestern, using the FCR001, and to provide some information about the ongoing Freedom 1 and Freedom 2 studies. And finally, to appreciate the importance of the patient community and general nephrology practitioners as stakeholders in contributing to innovation in the setting of renal transplant. So let's start with looking at the current state of the art, if you will, or landscape with living donor kidney transplantation and outcomes and treatment burden related to immunosuppression. And so this is data that many of you are quite familiar with, looking at survival probabilities, making the case that compared to dialysis, transplantation is certainly superior. And of the types of transplants we can provide, patient survival is superior with living donor versus deceased donor transplants. Certainly when you get out past 1 year, the curves separate for living donor and deceased donor transplant. Now, kidney transplantation is clearly associated with a lower long-term mortality risk and better quality of life for our individuals compared with dialysis. This next slide looks at graft survival, comparing living donor and deceased donor transplant. And I think we know this from our clinical practice that living donor kidneys have a longer estimated half-life and median survival rates as compared to deceased donor transplants. Now, the point's been made that we've made improvements over time, and we certainly have great 1 year, patient and graft survival. But when we go out long term, there's still improvements to be made. This is looking at survival curves for transplants as we go out from different eras from the 1990s through, the current time of the mid 2010s, and you can see around a third of all living donor kidney transplants will require a second transplant within 10 years because around a third of them will fail within 10 years. And so long-term transplant survival, this idea of one transplant for life, is something which we still have not been yet able to achieve. And we know that rejection accounts for around 17% of graft loss in the first year, but much contributes significantly more to graft losses after the first year, late acute rejection being a harbinger of development of things like antibody and is very, very bad prognostically. Now, the mainstay of transplantation to prevent graft rejection and extend graft survival continues to be chronic immunosuppression. There comes no point with current drug-based approaches where immunosuppression will not be necessary to control the immune system. And this is taken from the KDIGO guidelines recommending the current foundation of this immunosuppression usually be that of a CNI with an anti-proliferative agent with long-term maintenance therapy as shown here on this slide. Over 90% of patients in the United States are currently being maintained on a CNI-based immunosuppressive regimen to prevent rejection in the short term and long term. And we know that these drug-based immunosuppressive regimens have side effects. And we know that specifically with the CNIs, nephrotoxicity, direct damage to the allograft, many of the histologic features of CNI nephrotoxicity are shown here on this slide on the left-hand side. And this on the right-hand side is data that I think many of us are aware of that was published in the New England Journal showing the prevalence of CNI toxicity being nearly 100% of biopsies showing some degree of CNI toxicity when you get out to a decade. And so, you know, the road to hell is paved with the best of intentions, if you will. We're trying to control the immune response, but CNI-based immunosuppression comes at a cost, a direct injury to the allograft, and as we'll also talk about, other off-target effects that limit the quality of life, the life of the allograft, and sadly, the life of the patient. And so what are some of the risks associated with immunosuppressive therapy? Well, we know serious infections can occur. We see this very commonly in our practices for sure, and can lead infection is the leading cause of complications post-transplant. And there are common infections as shown here. We also know that vaccination may not be as effective in chronically immunosuppressed patients, and this is quite relevant in the current day and age of SARS-CoV-2. Malignancies, we know immunosuppression increases the risk of malignancies, and is the third most common cause of death post-transplant. We commonly see things like skin cancers, but other things like PTLD, which are quite problematic. And we know that the risk of malignancy, the increased risk is shown here. As we continue people on immunosuppression, there's risk which continues to stack up. With individuals who are younger looking at long-term maintenance immunosuppression, this is quite significant. We also know that these drugs can contribute to things like metabolic syndrome and diabetes. This cardiovascular disease is the leading cause of death with a functioning kidney graft, and this is exacerbated by the metabolic derangements which are affected by the immunosuppression that we use. We know that graft loss risk of graft loss is increased with things like post-transplant hypertension and diabetes as well. We know that there are other off-target effects like neurotoxicity, particularly with some of the CNIs that we use, like tacrolimus. The pill burden after transplant is quite significant. Patients have to take a large amount of medications. This polypharmacy is quite challenging for many of our patients to manage and can contribute to noncompliance. We know that pharmacogenomics plays a role, and drug-drug interaction can be quite problematic. And we know that finally, that non-adherence with the immunosuppression, which this can contribute to, can lead to graft rejection, late graft rejection, graft loss, and this is much more common in non-adherent individuals. And so lots of limitations with the drug-based approaches, which have been effective as a means to an end, but there continues to be continued room for improvement. This is a quality of life study looking at quality of life associated with chronic immunosuppression, a small study that looked at a group of patients who were off of immunosuppression, comparing them to conventional immunosuppression. And you can see that the scores for patients were much higher in those individuals who could be off of immunosuppression. And so there clearly appears to be a quality of life benefit if you can minimize or eliminate entirely the need for immunosuppression, which is, I think, a goal of the whole approach using the FCR001 therapy for tolerance induction. And so that brings us to talking about the donor stem cell therapy in question, the FCR001 therapy under current investigation to actively induce immune tolerance through the establishment of durable chimerism. So it's worth maybe taking a moment to talk about tolerance. And I think there are ways that this has been viewed and defined. I think a good working definition is one where you have a state in which the recipient's immune system can accept the donor organ, tissues, or cells, but is otherwise immunologically competent and capable of responding normally to foreign antigens and pathogens. It also isn't necessarily just an absence of any sort of response, but there are also active mechanisms like regulatory mechanisms, which in part we know relate to the FCR cell, the FC cell, in ways that it does work that help to maintain this immune tolerance over time. And so the value of establishing immune tolerance may be that you can discontinue chronic immunosuppression and sort of change the landscape for the patient, achieve this sought-after goal of maybe one kidney transplant for life with maintained renal function and avoidance of the many side effects we've talked about related to chronic immunosuppression. Now, one of the approaches which has been taken to achieve tolerance that harkens back to the work of Billingham and Medawar is to use donor-derived hematopoietic stem cells to engraft and establish something known as chimerism. And there have historically been challenges to inducing immune tolerance via an allogeneic stem cell transplant that relate to donor-recipient mismatch, affecting the ability to engraft, which becomes more difficult with mismatch. There's also the risk of graft versus host disease, where the engrafted stem cells may see the recipient as foreign and mount an immune response. And so you need an approach that can manage to these issues, which are two sides of the coin. And then you need to get stem cells to engraft, there needs to be some sort of treatment or conditioning of the recipient to get those cells to take. And it needs to be a regimen that whose toxicity and long-term complications will not be limiting and can be used in individuals who have end-stage organ failure, in the case of kidney transplant, and dialysis-dependent renal failure. And so the FCR-based approach is one in which the goal is to create chimerism, or a so-called dual immune system in the transplant recipient, by getting stable engraftment of immune cells from the donor, which then exist with remaining immune cells from the recipient. And this is a donor-derived stem cell product that's engineered to create the FCR001. And the goal again here is to achieve durable, sustained chimerism as a means to establishing robust and stable immune tolerance. And chimerism is an indicator of successful stem cell engraftment, may predict whether a patient can discontinue immunosuppression. And we have found, as I'll show you, that durable chimerism is a very good biomarker or indicator of the stability of this tolerance, this donor-specific tolerance over time. Now, the FCR001 is based upon the seminal work of Suzanne Ilstad, who in the 1980s identified a population of cells in the bone marrow that she called the facilitating cell. You can manipulate the bone marrow graft or peripherally mobilized stem cell product to enrich for the FC population, and also maximize or control the numbers of CD34s and have an allowable number of alpha beta T cells. And so this is all dialed in and controlled using a proprietary process. Preclinical studies over the last several decades have extensively detailed the biology of the FC, how it can assist in the homing of stem cells to the bone marrow niche, induce regulatory cells that can control rejection of the stem cells and graft versus host disease, and promote the fitness of stem cells. Translating this ability to enrich for the FCs from the animal model into a selection process that's proprietary and used in the clinic. And this was the basis of the work that we did in a phase 2 trial, which I'll now talk with you about. So this phase 2 trial was conducted at 2 sites, Northwestern and Duke. It began in 2009, and the last patient was enrolled and treated in 2016. A total of 37 donor-recipient pairs were enrolled and treated in this study. And this cartoon illustrates for you the basic structure. Donors and recipients underwent collections. The donor apheresis product was engineered to create the FCR that was cryopreserved and then infused into the patient the day after they received their kidney transplant, using non-myoablative conditioning based upon the regimen pioneered at Johns Hopkins using pre and post-transplant cyclophosphamide. It's a non-myoablative regimen. in which case, under the condition where the stem cells don't take from the donor, the recipient's own immune system will recover. We do, however, collect from the recipients an apheresis product in case a rescue infusion might be needed. With durable chimerism and normal biopsies following the infusion, the goal is to get individuals off of immunosuppression through deliberate immunosuppression withdrawal within a year. The eligibility criteria for the study is shown here. It was fairly broad, and with all levels of HLA mismatching between donors and recipients being allowed. And as of March of this year, around 33 subjects had greater than 3 years of follow-up, 29 had more than 5 years of follow-up. And we have a number of individuals I will mention off of immunosuppression now more than a decade with stable chimerism and robust donor-specific tolerance. So the majority of subjects enrolled in this trial engrafted in a durable way and could come off of immunosuppression. So as of March, 26 of 37 subjects had stable chimerism and came off of immunosuppression with biopsies out to 2 years showing no rejection, normal histology, and excellent renal function, no development of DSA. There were 27 patients who engrafted, but one of those patients did develop a late to diagnosed graft versus host disease that was treatment resistant and did not allow immunosuppression withdrawal, that did in fact contribute to subject death within 1 year. There were 8 subjects in the trial who had transient chimerism. In those individuals with transient chimerism, we did see 5 rejection episodes. There were 3 graft losses and 1 death in that group. And most of those transiently chimeric subjects lost the chimerism early post-transplant. There were 2 individuals who did not engraft at all. These were engraftment failures who had spontaneous recovery. Interestingly enough, one of these was a highly sensitized patient, which has led to responsive modifications to the protocol, and one had an underlying bone marrow disorder. Now, if we look at follow-up in the patients off of immunosuppression, you can see we have almost a half a dozen of individuals who are off of immunosuppression more than 10 years, with individuals with the least amount of follow-up off at least 2 years. And you can see here on the right-hand side of the slide, the degree of HLA match between the donors and recipients and who's off of immunosuppression. And what's remarkable is the degree of HLA mismatch between the donors and recipients in this trial where we could still establish chimerism without graft versus host disease and establish donor-specific tolerance. In fact, the first patient to come off of immunosuppression was a living unrelated transplant between 2 friends, and this individual is now off of immunosuppression, I believe approaching 13 years. We also looked at bidirectional HLA mismatch between the donors and recipients and didn't see any clear pattern of match leading to outcomes. We could achieve durable chimerism across all HLA barriers with very significant HLA mismatch being seen in individuals who could still successfully engraft and safely engraft and go on to be weaned from immunosuppression. We found that chimerism as early as 3 months post-transplant was predictive of durable immune tolerance. And so if you looked at month 3, we had 90 subjects with chimerism. They went on to discontinue immunosuppression at 12 months. Of those with durable chimerism, and here specifically at least 50% T cell chimerism, 96% went on to be fully withdrawn. And then by month 12, 100% of those individuals with durable chimerism came off of immunosuppression and have remained off of immunosuppression with significant long-term follow-up. Now, an important concept with these approaches to inducing tolerance is, does the end justify the means? Are we achieving better allograft function? Are we improving the quality of life of these subjects? Is the upfront infusion of this investigational cell therapy, the additional treatment, the cost, is it worthwhile? And the data we're beginning to see come out of the phase 2 trial is that an emphatic yes. We see much better kidney function in patients off of immunosuppression that's going out to 5 years. And this was an analysis we did comparing subjects in the black line here, who would have been eligible for the trial, but got our standard of care maintenance immunosuppression for a living donor kidney transplant. And there's a significant difference and better level of renal function in the tolerant subjects. We also looked at medication use for hypertension and hyperlipidemia, and our tolerant subjects need fewer medications to manage these aspects of cardiovascular morbidity. And we've also done quality of life assessments in patients off immunosuppression, and they score significantly better than matched individuals who are on standard of care maintenance immunosuppression. Another aspect of tolerance induction that we've looked at is whether or not this protects from recurrence of renal disease. Now, with chimeric tolerance, we have found with durable chimerism that individuals who had diseases where disease recurrence might occur, like IgA nephropathy, FSGS, membranous, those who engrafted and came off of immunosuppression, there was no post-transplant recurrence. Those with no or transient chimerism, we did see some element of disease recurrence. These are very small numbers, but there may be something to engraftment with a new immune system in the recipient that helps protect from disease recurrence of diseases that have a tendency to do so. What's interesting is that other roads to tolerance where no chimerism is established, so-called operational tolerance, the risk of disease recurrence has been observed. In fact, patients at high risk of recurrence are excluded from operational tolerance approaches by many centers. And so it may be protective against disease recurrence. Another question that we've asked is the immune competence of these patients restored following the conditioning and the stem cell infusion and repopulation of the immune system? And we see very robust leukocyte and T cell subpopulation recovery over 2 years, which is the period of time that in the allogeneic stem cell community, individuals have seen it takes for the immune system to recover. We've also been able to safely vaccinate and responsibly vaccinate these subjects successfully, and have recently reported results on COVID-19 infection and vaccination in tolerant subjects, showing that they behave like patients off of immunosuppression, not individuals who are on maintenance immunosuppression. Now, in terms of the recipient safety profile, there were no acute rejection or DSA development, no serious infusion-related reactions. Most of the AEs we saw in these individuals occurred while they are on immunosuppression during the first year of weaning. And you can see the description of the AEs here on the slide, the sort of things that we not uncommonly see in individuals who are receiving a kidney transplant or an allogeneic stem cell transplant. We did see rejection occur in this trial, but only in those patients who did not have established durable chimerism. There was no rejection in any of the patients with durable chimerism who were tolerant. Graft loss occurred in 3 patients in whom immunosuppression was markedly decreased or temporarily stopped because of severe infections. And you can see the timeline for graft loss in those individuals who were not in the the durably chimeric cohort. We have seen 2 cases of graft versus host disease in this trial, so an overall incidence of 5.5%. One was treatable, and that individual did develop some elements of chronic GVH, but is now entirely off of immunosuppression. The second was a higher grade, but was late to diagnosis due to poor communication with the subject and the patient being remote from our center. And this did contribute to death of the subject at month 11. And this led to responsive changes in the protocol to manage to reducing the risk of GVH moving forward. There were 3 deaths in the cohort of patients who were off of immunosuppression during long-term follow-up. I've already mentioned the subject who had graft versus host disease. And then there was a subject who did not get revaccinated for pathogens that you are recommended to get revaccinated for after stem cell transplantation and engraftment. And he contracted pneumococcal sepsis while traveling abroad after not having been properly vaccinated against pneumococcus. And then there was a patient who was a heavy smoker who developed a late-stage lung cancer 4.5 years into the trial, 3.5 years off of immunosuppression. Finally, there was 1 death in a transiently chimeric subject that took place at 4.5 years related to opportunistic infections while on maintenance immunosuppression. Now, when we think about the donors, and let's not forget that the donors are undergoing a mobilized stem cell collection. The AEs reported in the donors were mild to moderate, nothing serious. They were pretty consistent with what people experience when they get GCSF to mobilize stem cells for collection, and occurred around the time of the administration and stem cell mobilization and apheresis. So on the strength of the results of the phase 2 trial on living donor kidney transplant, this technology was now advanced by Talaris Therapeutics into a phase 3 so-called Freedom-1 study. The Freedom-1 trial is designed to further evaluate the safety and effectiveness of the FCR001 cell therapy. It's a randomized multi-center study. The primary endpoint is the proportion of subjects who can get off of immunosuppression without rejection at 2 months post-transplant in the treatment arm. And a key secondary endpoint is looking at renal function out to 2 years, excuse me. Here's the overall design of a study. It's a 2-to-1 randomization scheme with 80 subjects in the treatment arm, 40 in the control arm. The same mobilization strategy to get the donor's FCR created, which is then cryopreserved, and then the recipient has the rescue collection. Conditioning, as described before, non-myoablative, with pre- and post-transplant cyclophosphamide. It's around a 4 to 5 day conditioning regimen, followed by the FCR infusion the day after kidney transplant. Tacrolimus and mycophenolate maintenance immunosuppression as in the phase 2 trial, and then withdrawal of immunosuppression based upon milestones, specifically durable chimerism, normal protocol biopsies, absence of DSA, with full withdrawal of immunosuppression by design at 12 months post-transplant, with the primary endpoint being an analysis at 24 months. Inclusion and exclusion criteria are shown here. Patients have to be negative for COVID and also have to be vaccinated against COVID-19, but fairly broad inclusion criteria. Again, no restrictions in terms of HLA match between the donor and the recipient. The only exclusion, I think, is identical twin transplants. PRAs are greater than 80. You have to be ABO compatible. Because of the observation that GVH occurred in biologically unrelated female donor to male recipients, that's also been included as as an exclusion criteria for the trial. And so this comes up not uncommonly with spouse-to-spouse transplants where this will not be possible to move forward. And so it's just something to keep in mind if you're thinking about your patients. A companion trial that's also being conducted using the FCR technology is a so-called Freedom-2 trial. This trial is asking the question of whether or not we can disconnect the tolerance induction with the FCR therapy from the kidney transplant in time. And the idea would be to have individuals recover from a kidney transplant, and then at least 3 months after the kidney transplant, then take them through the tolerance induction using the FCR with the conditioning I've described. This would lay the foundation, if successful, to applying this approach to deceased donor transplant. So it's a very important study to lay the foundation for using this approach in deceased donor kidney transplants. This is an open label trial that will be looking at, I believe, a total of 15 donor recipient pairs of living donor kidneys, at least 3 to 12 months, in a 3 to 12 month window after kidney transplant. The primary and secondary endpoints are similar to what you saw in Freedom-1. Again, here, individuals who are eligible by having a normal protocol biopsy at 3 months after their transplant with no evidence of rejection or sensitization against the donor can be enrolled, the same sort of mobilization and engineering to create the FCR. And if there's durable chimerism, discontinuation of immunosuppression, as shown here. And again, all levels of HLA mismatching between the donor and the recipients will be allowed here. And here are the inclusion and exclusion criteria, very similar to what you saw for the Freedom-1 study. One caveat here is that induction therapy Alemtuzumab induction because of concerns about the effect of alemtuzumab in a durable way on the recipient is an exclusion. And so if subjects express an interest in this at our own center, which uses alemtuzumab, we avoid the use of alemtuzumab to allow them to be eligible and considerable for the study moving forward. So in summary then, I hopefully I've been able to sort of convince you of the limitations of chronic immunosuppression, that it imposes significant health benefits and quality of life burdens on our patients. I've hopefully been able to explain some of the rationale and our experience with the FCR001 in the phase 2 trial, and the design of the Freedom 1 and Freedom 2 studies, which were advancing the FCR technology in a phase 3 study with respect to Freedom 1, and earlier phase non-randomized evaluation in the Freedom 2, which will hopefully, the latter, lay the foundation for an approach that will be user-friendly in the context of deceased donor transplantation. Now, if you're interested in learning more about Freedom 1, there are many locations around the country that are open and enrolling subjects. You can find that information about the Freedom 1 trials at the website shown on the slide, as well as for the Freedom 2 at clinicaltrials.gov or the Talaris website. I'll just leave this up here for people maybe to take a note of. And so, with that aspect of our presentation completed, what I'd like to again do is invite and introduce Gisela Delgado, who will talk to us about embracing the voice of the patient. Gisela, I have the pleasure of driving the slides for you. So just let me know when you'd like me to advance.
No worries. There's only 2, so it's I made it easy.
All right. Well, I'll move on to your next slide.
Thank you. This is just a quick introduction of me as a patient. Also, just a disclaimer, I am not a part of this trial. I just became heavily involved in patient advocacy about 4 years ago after my transplant. And so I'm happy to be a part of the Talaris Patient Advocacy Advisory Council. And I also sit on the leadership team of the IgA Nephropathy Foundation. But I could watch this presentation over and over again, and to me, like it gives me so much hope of what other people will hopefully not have to go through, some of what I went through in my journey. We go to the next slide.
Certainly.
So I talk pretty fast. I'm from New York, so I think sometimes it's helpful to just have kind of milestones for people to remember who I am as a person. So in 1981, I was born in Bronx, New York. I was a premature baby by 1 month, but otherwise very healthy. In the winter of 93, I had flu-like symptoms and was had an upper respiratory infection. And then in I thought I was getting better. I went to the restroom and I presented some Coca-Cola urine, and thus began something is going on with my kidneys. And I would say that happened probably in November, around the holiday season of 93. And it took about 6 months for me to be diagnosed, ultimately via kidney biopsy. And that brings me to, I'm a freshman in high school. It's 1994, and I've been diagnosed with IgA nephropathy. At the time of my diagnosis, I wasn't told much. I was told that I was lucky in a sense because I had been diagnosed very early, and that if ever there was a kidney disease, this is kind of one of the better ones because it's a slow progressing disease. But likely what would happen is in about 20 to 25 years, I would ultimately end up needing dialysis or transplant. So we fast forward to 2011. I'm about 30 years old or so, and I end up in the ER again with stomach flu symptoms, feeling pretty crappy. I had had the flu, recovered 2 weeks later. Now it's back. In 2011 was essentially where I had progressed to a stage 3A or so with my kidney disease. And it became clear that the transplant or dialysis was going to become inevitable. And from this point on, there's a series of tests and stuff and trying to figure out the right cocktail. But one thing I was very grateful to my doctor for was reminding me that even though the only thing I really had to look forward to was transplant or dialysis to help my kidneys, was to try to think of a preemptive transplant and how I can find a donor. And that's what ended up happening in 2017. In 2017, I ultimately reached kidney failure. And it took a while for me to find a donor. And that's due to, I take some blame there as far as like not being vulnerable. As a patient, I will tell you all that looking for a kidney donor is a full-time job. It's not like when you need a bone marrow transplant and there's teams of people that just, go into a database and help you. It is very overwhelming as a patient to have to worry about how I'm going to save my own life, because there is no medicine that can help treat or cure my disease. The only thing I have to look forward to is a kidney. And to get that kidney, I need to learn how to advocate for myself. I was very fortunate in 2019 to be able to receive a preemptive transplant from a living kidney donor, and that was my brother. Now, we could go to the next slide. Think about February 2019 and what happened a year later. There's a thing called coronavirus that appeared. And I put this slide together. I work in graphics and marketing, and the road to transplant is pretty stressful. Some of the things I just mentioned, you're trying to figure out what your diagnosis is, several tests, labs, trying to figure out what is the right cocktail for you as a patient. Depending on when you were diagnosed, it can be extremely overwhelming. I would say I was fortunate that I was diagnosed so young, and the internet did exist back in '94. It wasn't what it is today, but over time I was able to find out as much information as I could. I was able to avoid dialysis. It was made very clear to me very early on that that was my best chance for a better transplant success long term, and also that I should really try to get a transplant from a living donor. And it's like peaks and valleys, and this is what I feel visually that it feels like, because even after you get your transplant, it's not like you're good. You're not done. I was aware, as you start to read about transplant and the drugs that you're going to be on for the rest of your life, that they were strong drugs. I really didn't have a lot of options as to the types of drugs I could take. There's about 3 or 4 drugs that almost every patient is on post-transplant, different cocktail mix, and or any other medical conditions that they have and how those drugs interact. And post-transplant, a year post-transplant was the start of the pandemic. That was a pretty scary time to be immunocompromised while this disease is coming to life here. And then also, just getting care. No longer was it safe for me to jump on the train to go to a doctor's appointment, trying to make those extra adjustments, getting set up for home labs took way longer than, I hoped. And that's something that it's unfortunate, because I know a lot of patients, even to this day, they haven't been able to get home labs during the pandemic crisis. Post-transplant, then due to immunosuppression, you're constantly being checked for other things, like you mentioned some of them, but BK virus, any donor-specific antibodies appearing. You really can't relax, because you're not just testing your kidney function. It's all these other things that could happen. And for me, the most frustrating, I would say, is that I don't have a choice in this matter. I have the drugs that I'm supposed to take, and I have to take them every day at the same time, twice a day. And it's not like if you forget to take, a different type of medicine, like if I just had diabetes or something, like this is every time you miss a dose, the chance for rejection increases by a small percentage. And it's really sometimes really scary. And if you're not like a process oriented person, if you don't have support at home, it might seem really easy to remember to take a medicine twice a day, but there are days where you don't feel well. There are days where maybe you weren't home and you forgot to put something in your car, or you're tired. It's a big burden. And there are times where I might even freak out if I realize that, wait, I look at the date, I keep everything pretty organized, and I'm like, did I refill my thing today and that's why it's empty, or did I not take my medicine? And then sitting in that moment, because a double dose is even worse, putting my body into extreme toxicity. So it's not like I could just take it just in case. Right in the middle of pandemic, something else that I wasn't aware could happen, being on immunosuppression, but it makes sense, is I developed the shingles. And it's pretty crazy that a 40-year-old person could get the shingles. And it was just, speaking to my doctor team, it was made evident that it wasn't because I was stressed. It's just something that happens sometimes. And it was like, oh, like that's not something that's like a highlight post-transplant. And then also now, even for me to get treatment, to get approved to get the shingles vaccine is a whole nother process I have to go through right now, because I quote unquote don't meet the criteria, even though I already had the shingles. I'm looking over some notes here, and I think the biggest thing I would say, and having this opportunity to speak to people who are helping people, is there's not a lot of times during your diagnosis as a patient that you feel you have any options. And being exposed, I think, to clinical trials, the average patient is not going to think at the time of diagnosis or that they need a transplant to go do that research. And I think that I know it's hard, and doctors have many patients, and care teams have many people that they see. But I do think overall education and making information accessible to the larger community, so that I can feel like I'm making an informed decision, and I'm doing something that's going to work best for me, especially for people that, like I said, finding a donor is hard, but there are ways to help people, educate them, start that process earlier on, so then getting enrolled in a clinical trial doesn't feel like an extra burden. It feels like an informed decision that someone is making. And seeing the advances that have happened in science, even in the past 5 years, is pretty promising. But immunosuppression, as someone who's on it, I'm going to be on it for the foreseeable future. There are a lot of side effects, with the gut health. And most things, if they appear, like the treatment is just like adjusting the dose. It's not like, oh, well, let's take you off of this and try something else. I'm just dealing with the same amount of pills every day. You mentioned it in your presentation, the burden of pills, like it doesn't fit in that little travel case. I had to get like a special one with extra compartments so I can keep extra pills on me. And it's, I have these 14 pills a day that are saving my life, but they're also maybe hurting it at the same time, because the risk of kidney disease coming back, the risks of toxicity. And I've been told how lucky I am to be young and get a second chance at life. But what am I, and I am grateful, but thinking about it, it's like, I know I'm taking this medication that's hurting me. It's saving my life, but it's also like not doing the best. And not having any options or choice in that is tough. And I am grateful for my medical team for explaining things to me in layman's terms, which I think is really important. It's not hopeless. There's a lot of new science out there, but I would encourage, when speaking with patients, even if you're not aware of the latest clinical trials, to just ask them how they feel about it. And if they don't feel like they know anything about it, how could you explain it to them? that's pretty much my story as I could tell it in about 10 minutes or so, but I'm open to questions, and thank you again for this opportunity.
Thank you, Gisela, for sharing your experience with us today. And want to thank everyone for their time this afternoon. I hope you found the webinar informative. I want to thank my co-presenter, Gisela Delgado, for her time today as well, and sharing her experience as a transplant recipient, her journey. It's always, I think, important for us to hear things from the patient perspective, and to keep that importantly in our minds, top of mind, as we consider what the options are out there and discuss those options with our patients. So with that, I'll thank everyone for their time this afternoon. This will bring this webinar to a close. Thanks again.